Assalamu alaikum. I'm Hiba Rashid, a third year student from Ziauddin University. I used to believe that if the patient could see the problem, they would be compelled to solve it. But that is not the case. Today, I want to explore with you not just the power of visual design in dentistry, but its limits, and more importantly, how we can redesign our approach so that the visuals don't just capture the eye, they capture the mind. Let's name this assumption: the idea that seeing leads directly to doing. In psychology, it's linked to the concept of cognitive fluency. The easier something is to see, the easier it is to believe we understand it. In dentistry, it is embedded into so many of our tools. We show, they see, we presume understanding, we expect change. But what if that chain is broken? What if there is a gap where meaning is lost, where motivation is evaporated? I call this the glitch in the visual prescription. Let's examine one of our most trusted visual tools, the plaque disclosing agent. Studies have shown while visual feedback in the moment can create a reaction, it does not on its own lead to improvement. Think about that. We have a tool that makes the invisible visible, that turns the abstract plaque into tangible colored stain. And yet the behavior doesn't stick. Why? Because the stain shows the what. It does not explain the why. It does not answer the patient's silent questions. What does this matter to me? What happens if I ignore it? What will change if I do better? Without those answers, the visual is just a spectacle, a momentary shock, not a lasting insight. So we have our glitch. The visual signal is sent, but it is not received as meaningful information. It becomes noise. In communication theory, a signal requires three things: a sender, a message, a receiver who understands the code. In our case, we are the sender. The steen tooth is the message. But if the patient doesn't have the code, the context, the relevance, the personal connection, the message is just static. This is where our roles shift. We are not just providers of visuals, we must become designers of understanding. So, what's the fix? The research is clear. The variable that does correlate with long term behavioral change is consistent, personalized, reinforced education. Education is not a soft skill adjunct to a hard visual tools. It is the operating system. It is the framework upon which every visual, every app, every camera feed must run. It provides the why. It builds the bridge between what the eye sees and what the mind chooses to do. Let me say that again. The visuals provide the evidence. Education provides the meaning. And meaning is what inspires action. Let's rewrite the prescription. In practice, this is what an upgraded visual prescription looks like. Research shows that intraoral cameras significantly improve plaque control and gingival health compared to standard oral hygiene advice alone. They personalize the explanation, turning abstract advice into concrete, patient specific understanding. One of the most powerful visual tools we now have are mobile health apps. They allow oral health information to reach patients anytime, anywhere across all age groups. And that accessibility matters because prevention and healthy behavior don't happen during appointments. They happen at home, in routines, in repetition. So here's our challenge and our opportunity. We are not just adopting technology, we are designing clinical experiences. Every visual we use, every camera, every app should be filtered through one question. Does this help my patient understand their own story? If the answer is no, it's just noise. If the answer is yes, it becomes a tool for empowerment. This is the shift from patient compliance to patient partnership, from showing to explaining. Let's move beyond the hype. Let's use design not for spectacle, but for insight. Let's not just make patients look, let's help them see. The true power of visual design is not to shock the eye, it's to illuminate the mind.